So we welcome you all to this session. Great that you are participants in ophthalmic trauma session, which is a very important field, which we need to be all embracing, because that's an area where a huge improvement is possible with interspeciality coordination. So we want all those with interest in ophthalmic trauma to advance in that field, become coordinators in their institutions once they get into tertiary institutions, so that the trauma management can be drastically improved from present, because there's a lot of research that needs to be done to have protocols which is so far lacking. So hope that you will all become future researchers of ophthalmic trauma. So I look forward to the presentations. Dr. Sanjeev will handle.
We have the first, Jofi Phillips is here? Yeah, so you can present your first case. And the second speaker after that would be Uja Sharma. Right, so be ready. So please stick to your time, 4 minutes. And
good afternoon. I would like to thank the Scientific Committee of APAO and AIOS for giving me this opportunity. Clinical profile of open globe injuries at workplace, a study in a quaternary care institution. As we all know, ocular trauma is the most common cause of ophthalmic morbidity and monoocular blindness, with globally 55 million eye injuries occurring yearly, according to WHO estimates, with a cumulative lifetime prevalence of ocular trauma as 20%, that is 1 in 5 persons. Most patients with open globe injuries are men, and the occurrence is at workplaces. Various factors influences the prognosis, which includes pre-op visual acuity, presence of relative afferent pupillary defect, and the location of ocular trauma. The ocular trauma score is a prognostic model developed, which factors in considerations are the best corrected visual acuity, globe rupture, endophthalmitis, perforating injury, retinal detachment, RAPD. The aim of the study was to study the clinical profile of patients presenting with occupation-related open globe injuries. The methodology design was a prospective observational study, and the inclusion criteria were patients presenting within 1 month of injury at the workplace and those above 18 years of age. And the staffs and students of Christian Medical College Vellore were excluded from the study. Out of a total of 88 patients, we had 11 patients, or 12.5% of patients presenting with open globe injuries. All patients with open globe injuries were from the lower socioeconomic strata according to the modified Kupusamy scale. Open globe injuries were more common in those with primary school education and those with higher risk for presenting with worse vision. The metal foreign body was the most common cause of injury in the industrial sector. This was followed by welders and those involved with grinding metal or stone. Out of a total of open globe injuries of 11, we had 4 patients with retained intraocular foreign bodies. The profile of ocular injuries is illustrated in the table, and the cause of low vision at 1 month presentation were due to vitreous hemorrhage, retinal detachment, corneal scarring, and aphakia. Now, this is a table of profile of patients with open globe injuries with retained foreign body. The first patient is that of a mason who, with injury occurring to the eye as a result of hammering a nail into the wood, and the nail chip flew. He presented with a vision of 260, and at 1 month follow-up, he had a vision improvement of 636. The second case is of that of a stone quarry worker, and the injury occurred while hammering stone. He had a presenting vision of 6.9, and it remained the same. The third patient was that of a grinding worker who, with the injury of grinding stone with a machine. The vision was poor of perception of light, which remained the same at 1 month follow-up. The fourth case was that of a truck driver who was working in a stone quarry, and the blast injury occurred at workplace. His vision improved from 636 to 66 at 1 month follow-up. This is a profile of patients with open globe injuries with no retained foreign bodies. And the profile of patients were that of farmer, stone quarry workers, and mechanic and electrician. The patient, the farmer who incurred open globe injury due to cutting branches of the tree, his vision improved from hand movements to 624, while that of the electrician, it improved from 618 to 69, and he had occurred, the injury had occurred while cutting metal wire. That of the stone quarry workers, the vision were poor. in both the patients with hand movements at the time of incidence, and one patient improved to 612 while the other patient did not improve. Then we had two farmers who presented with perception of light and their vision improved to counting fingers at 1 month presentation. Case 7 was that of a mechanic whose vision improved from 160 to 612, and he had, the injury had occurred while chipping metal. The last patient is that of a farmer whose vision improved from 636 to 618, and the injury had occurred while working with stone and stone quarry. In discussion, I would like to say that closed globe injuries are more common than open globe injuries, and the most common most common is that of a metal foreign body in the industrial sector and that of vegetative matter in the non-industrial sector. Most patients will have an improvement in visual acuity following surgical intervention. Final visual acuity after open globe injuries can be better than 20/14 up to 39% of patients, and the visual outcomes were consistent with that of the ocular trauma score study. And the incidence of open globe injuries are decreasing with more rampant usage of personal protective equipment. Occupation-related trauma is a preventive cause of injury, and most of these injuries occur in the unorganized sectors and those like stone quarries and domestic animal owners. Public health awareness and use of safety devices is of utmost importance, and adherence to stricter national laws is important, and this needs to be included in the public health agenda. PPE usage, according to various studies, has highlighted the importance of decreasing the incidence of open globe injuries. With this, I conclude. Thank you.
Thank you. You were mentioning about the open globe injuries. That's your topic is.
Yes.
So you mentioned a lot about the foreign body, metallic foreign bodies or vegetative matter.
Yes.
So did it really go, was it intraocular?
No, the foreign body, the vegetative matter was not intraocular.
Right.
We had included a study of 88 patients, which included both open globe and closed globe injuries,
So
and we used a subset of.
So basically,
11.
the open globe includes, basically, it means a intraocular.
Yes.
So I feel, personally, I feel that it can't be included in your, should not have been included in your topic, like a foreign body, metallic foreign body. Did it penetrate the cornea?
Yeah, we included only those that have penetrated the cornea.
Ashish?
When was, though your study is on the clinical profile, but you mentioned the final visual acuity, what was your intervention, and did anybody had infection or anything, and what was the time interval of intervention? That is something that should have been mentioned in this.
Yes, so with the patient with vitreous hemorrhage and retinal detachment, we intervened immediately within 2 to 3 days, and the final visual acuity was taken at 1 month presentation.
And the foreign bodies, retained foreign body use?
Yeah, that was also
how
taken.
long was it retained?
We operated within 3 days.
3 days.
Yes.
Size of the foreign body was not mentioned there?
It was about 2 to 3 centimeters.
Any of these patients had an infection when you were doing the surgery, or did you give intravitreal antibiotics?
We did not encounter any infection. We had given intravitreal antibiotics, but we didn't encounter any infection.
So I must say that you've actually presented a good clinical profile of open globe injuries, which have been both farmers, the industrial trauma. But I would say that specifically in these subsets, what you need to do in these cases, any take-home lesson for that, if you could, convey to us, that would be even better for the study.
Yeah. Over the years, I felt that protective eye equipment has not been incorporated in all these sectors, and we still see patients who have incurred open globe injuries and also closed globe injuries with metallic foreign bodies. The reason being that they've not been using protective eye equipment, and the companies or the sectors where they're supposed to encourage workers to use protective eye equipment are not encouraging them, and some of them are not even doing it maybe out of ignorance. I feel that this is important, and this needs to be included in the national agenda, public health agenda also. because most of these injuries, they go unnoticed.
Absolutely.
And yeah. Thank you.
Thank you. Can we have the next speaker, Dr. Urja Sharma? You'll be speaking on a tail of retained spiky plant thorn in the orbit. Any speakers who come a little late, they'll be taken at the last. We'll take the attendance again at the last. Slides, please. Okay, carry on.
Good afternoon, everyone. So I'll be presenting a case on a tail of a retained intraorbital thorn. So retained intraorbital foreign bodies are very common in ophthalmic practice, and they can have varied clinical presentations like orbital cellulitis, draining sinus, injury to the globe and to the optic nerve. And clinicians are faced with a diagnostic challenge in all such cases, especially without a good clinical history. The nature of the foreign body also plays a decisive role in diagnosis and management. So I present to you a case of a 32-year-old male who presented to our IOPD with complaints of swelling in the lower lid, pain and discharge from the swelling since 3 months. The patient also gave us a history of a fall on a bush 4 months back, after which the patient remained asymptomatic for a period of 1 month. On examination, it was found that the uncorrected visual acuity was 6/6 in both eyes, with full and free ocular motility. On inspection, we found that there was a swelling of the right lower lid with a discharging sinus, which measured 0.5 into 0.5 centimeters. On palpation, it was found to be a firm, tender, indurated swelling, and rest of the ocular examination was unremarkable. So we sent a culture of the swab from the discharging sinus, which showed no growth of organisms, and a non-contrast CT orbit was obtained, and it showed a linear hyperdense foreign body in the inferolateral aspect of the right orbit, which was directed towards the orbital apex. So this patient was started on systemic antibiotics and analgesics. The patient underwent a wound exploration with excision of the sinus tract under local anesthesia, and a plant thorn measuring 2 centimeters was recovered from the wound. Systemic antibiotics were continued post-operatively. So in the images, we can see that there was a foreign body granuloma which had formed around the thorn. And once we incised the granuloma, we recovered a 2 centimeter long wooden thorn from the wound. So CT scan of the orbit is the imaging modality of choice for a retained intraorbital foreign body. However, identification of wooden foreign objects can prove to be very challenging because dry wood usually appears hypodense, like entrapped air, while fresh wood is isodense with fat, and this complicates detection and it can be easily missed. Imbibation of fluid due to a prolonged retention can increase the density and make it more visible on imaging. So systemic broad spectrum antibiotics and anti-tetanus prophylaxis are imperative in such cases, and retention of organic foreign bodies has a much higher rate of infection and inflammation, and thus they should always be surgically removed. So in conclusion, any draining sinus in the periorbital area, especially in the setting of a chronic infection, should raise suspicion of a retained orbital foreign body. Thank you. These are my references.
A very good presentation. In this case, I feel MRI also would have been a better
Yes,
diagnostic choice, I know.
Yes,
Because
ma'am.
non-metallic foreign bodies.
Yes, ma'am.
And was there any organism positive after you sent the sample?
No, ma'am. On the culture swab, there was no growth, but the orbital foreign body that was recovered, we didn't send that for culture.
Sometimes
You
if
didn't
the
send that
We
for
didn't send that for culture.
any
I think.
particular reason for it?
No, sir.
Okay.
No, it helps us to manage
Yes.
further.
I think I'm just from the teaching point of view, anything you take out from the body needs to be sent for
Sent for
pathological examination. to say, just a teaching. And so that is for all of you. Any kind of mass or foreign body should be sent for those. So you get a lot of information thereafter. So that is what. Anyhow, thank you. But overall, a good presentation.
Thank you.
Thank you. Right, sir. Can we have the third speaker, Dr. Soumya Perry? She'll be speaking on eyes of the future, predicting visual acuity in pediatric corneal trauma and traumatic cataract.
So, eyes of the future, predicting visual acuity in pediatric corneal trauma and traumatic cataract. Introduction. Ocular trauma is an important cause of preventable visual morbidity and acquired unilateral blindness in the pediatric age group. The knowledge about epidemiological, socio-demographic aspects, causative factors, visual outcomes assume special significance in trauma-related blindness of a child, as a child suffers from more blind years than that of an adult. So the aim of the study is to study the incidence, demographics, clinical profile of ocular trauma in pediatric patients and evaluate factors influencing final visual acuity in post-corneal trauma cases, blunt or penetrating with adjunct traumatic cataract. A retrospective study of 15 pediatric eyes who presented with unilateral corneal tear with adjunct traumatic cataracts were reviewed. We evaluated age at trauma, gender, trauma type, blunt or penetrating injury, cause, zone of injury, duration between trauma, primary corneal tear repair and cataract surgery, IOL implanted, and BCVA. So coming to the results, high prevalence of ocular trauma was seen in males as compared to females because of more engagement in outdoor activities. Patients with OTS score of 5 had a relatively better visual outcome. Zone 1 injuries were more common in our study. Blunt injuries outnumber the penetrating ones. Most injuries in our study were caused by objects such as wooden sticks, pencils, metallic objects, stones, glass pieces, vegetative matter, which cause more of penetrating injuries. So coming to the main results table. So 6 out of 15, that is 40% cases with penetrating injuries had primary corneal tear repair followed by traumatic cataract extraction, IOL implantation 4 to 6 weeks later. 3 out of 6, that is 50% cases, had a visual acuity of 6/18 or better. 9 out of 15, that is 60% cases, had blunt trauma with adjunct self-sealed corneal tear or scar and had primary IOL implantation earlier. 7 out of 9, that is 77.7% cases, had a visual acuity of 6/12 or better. So here is an example of a 3 mm corneal tear. After primary tear repair, the vision was 2/60, but after IOL implantation post 6 weeks, the vision improved to 6/9. Another example of an inverted L-shaped 4 into 4 mm corneal tear. After primary tear repair, the vision was 2/60, but after post-IOL implantation, the vision improved to only 6/36 because of the dense stromal scarring in this patient. So dense stromal scarring, vitreous hemorrhage, and retinal detachment contributed to poor visual outcome in 3 cases post-penetrating injuries. 2 cases had chronic retinal detachment following late presentation of blunt trauma and had PL negative vision post-cataract surgery. So coming to discussion, we obtained a satisfactory visual outcome in children with traumatic cataracts. Blunt trauma had better final visual acuity than penetrating injuries. In case of penetrating injuries, we preferred repairing corneal laceration first and performing cataract surgery when the inflammation subsided after 4 to 6 weeks on an average. PCL implantation with 3-piece IOL was preferred in all cases, along with phacoaspiration, which was done successfully. Rate of PCO formation has been reported to be higher in pediatric eyes with traumatic cataracts as compared to the non-traumatic cataracts. But in our study, this incidence was low, as primary posterior capsular rhexis or PCC of 3 to 4 mm size was done in all cases, which maintained a clear visual axis and also reduced the incidences of pupillary optic capture. So we recommend phacoaspiration with PCIOL, PCC, and anterior vitrectomy in children with posterior capsular plaques, anterior capsular tears or thickened membrane, and also in older children. In children, to prevent stimulation deprived amblyopia, surgery is done as soon as possible with intermittent patching of the other eye to avoid amblyopia. Intensive topical steroid therapy is given for a long period, say about 2 months, in a slow tapering phase to avoid post-op inflammation and uveitis, which is more common in pediatric traumatic cataracts. So here is an example of a case where a thickened fibrotic plaque is successfully removed by initiating with the help of a cystitome cut with a 1 followed by traumatic cataract extraction and successful implantation of IOL in the pediatric patient. To conclude, early management of primary corneal tear, depending on its location, followed by traumatic cataract extraction with IOL implantation, can result in a better visual outcome. Blunt trauma had better final visual acuity than penetrating injuries. Eyes that underwent primary posterior capsular rhexis in a clear corneal area plus anterior vitrectomy combined with lens aspiration, IOL implantation had better final visual outcomes. Penetrating injuries, being the most common type of injury, necessitates adequate preventive measures in the form of parental counseling, child awareness drives in schools, with emphasis on adequate precautions, preventive measures, and immediate ophthalmic consultations in the event of an injury. These are my references, and thank you.
Very nice presentation and good take-home messages. But one question is that any patient who had a corneal trauma with capsular tear, when did you intervene in those patients the second time after the primary corneal tear repair?
Sir, actually depends upon if there is a cortex disturbance associated with it. But if there is a cortex disturbance or if there is an ALC tear also, first we would like to go for the primary corneal tear repair. And we would like to give medical management depending upon the etiology of the injury. Say if it is a stick injury or a vegetative matter injury, we would not put it on steroids. Post-op management will be more of antibiotics, antifungals. But still we would like to wait till the inflammation subsides at least for 1 to 2 weeks, because when there is inflammation, there is always association of endophthalmitis can happen, and we want to go for PPC for every case. So if you are doing a PPC, there is a disturbance of anterior vitreous phase, and when there is a disturbance of anterior vitreous phase, then high chances of endophthalmitis can happen. So we would like to see the timing. We have to titrate case to case basis. So primary corneal tear repair followed by, we have to observe the patient. If the inflammation has subsided, if the patient is doing well, then we can take it in 1 to 2 weeks if there is a cortex disturbance. But if there is any no cortex disturbance, we can wait till 4 to 6 weeks. So that's what we normally follow.
What was the incidence of pupillary block glaucoma in these cases?
Pupillary glaucoma, normally we have not found, sir, madam, because we normally do a prophylactic PI before after doing the cataract extraction. So normally we have not found, and we always in a post-operative medical management, we do Actimolate.
How did you calculate the IOL calculation, the A scan?
A scans are of the better eye, because penetrating injuries and with scar, it is always very difficult to get for the affected eye. So for the better eye, whatever like we have done with that.
So whatever you got for the better eye, the
Yes,
fellow eye, you had put the same implant.
Approximately.
Is there any role of pentacam or topography or doing for both the eyes to see the astigmatism, or a B scan?
Sir, in those cases where we have waited for 4 to 6 weeks, we used to do, we have done for only few cases, topography, to see how much is the astigmatism, and if it is necessary, we could have gone for a selective suture removal so that the astigmatism is less. But then as a protocol, we have not done for every case.
And there's another important factor is that you should always see the refractive error. In case the child is wearing glasses, check
Yes.
for the refractive error for the fellow eye. That will give you more accuracy towards your IOL power calculation.
And B-scan comparison also helps,
Yes,
I think,
that
sir.
is what I
like
What was the age group of these patients?
Sir, on an average from 4 to 12 years, sir, in a little...
So you used to do PCC in all these cases?
Yes, sir. Our pediatric doctor has done for every
And
case.
PCC with anterior vitrectomy?
Yes, sir.
Right, thank you. And one more suggestion. This is probably your first or second time. When you speak a little slowly. You were running. So it takes a little time for all the others to
Sorry, sir,
understand.
adrenaline
You'll
rush.
get used to it with passage of time. But
Thank you, sir.
good, thank you. So we'll have the third speaker, Dr. Sonam Gill. She'll be speaking on ocular trauma, the hidden cascade of curses.
Good afternoon, everyone. Myself, Dr. Sonam Gill. Before proceeding, I would like to thank the scientific committee of AIOS and APAO for giving us this platform to present in front of such eminent personalities. So my topic is ocular trauma, the hidden cascade of curses. It is a case series. Our first case is a 23-year-old young male with history of blunt trauma to the left eye by ball while playing cricket, with chief complaint of sudden painful diminution of vision in the left eye. And on examination, he had a best-corrected visual acuity of finger counting close to face, and fundus finding had vitreous hemorrhage, commotio retina, and retinal dialysis in the periphery. And his OCT showed abnormal vitreoretinal interface with distorted IS-OS junction. So we started the patient on oral and topical steroids, and we did laser barrage for the left eye in view of retinal dialysis. And we took a fundus photo at 4th week, which showed reduced vitreous hemorrhage and choroidal. So we were able to see the choroidal rupture in the temporal half along the disc. Weekly follow-up visits showed that the patient had improvement in the visual acuity. Our first Our second case is 74 years old female with history of trauma to the left eye by wooden walking stick due to accidental slip and fall. And chief complaints were gradual painless diminution of vision in the left eye. An examination showed best corrected visual acuity of finger counting of 1.5 meter in the injured eye with large macular hole in the on fundus examination, and OCT confirmed the full thickness macular hole. We did a left eye pars planar vitrectomy for this patient along with internal limiting membrane peeling with C3F8 air under local anesthesia, and we on post-op we give the patient topical antibiotics and steroid along with IOP lowering agents. So this is the pre-op and post-op OCT of the same patient. Our third case is a 12 years old male referred to us with suspicion of right eye endophthalmitis in view of right eye corneal tear repair 1 week back, in view of right eye full thickness corneal tear with iris prolapse, post-trauma to the right eye while playing, with chief complaints of painful diminution of vision. An examination showed best corrected visual acuity of PL positive and PR inaccurate in the same eye. An anterior segment showed that there was a diffuse corneal haze along with membrane in the pupillary area and poorly dilating pupil with synecdoche formation and traumatic cataract. There was absent glow with media clarity of 4+, so rest of the details were not visualized, and we did a B scan for the patient and we could see that there was an exudative membrane in the posterior segment suggestive of endophthalmitis. So we gave an intravitreal antibiotics for this patient, but there was no improvement post 48 hours, and so we did right eye pars planar vitrectomy with lensectomy along with IL implantation in the secondary setting, and post-op management included oral and topical antibiotics and steroids. A fourth and final case was a 17 years old male with firecracker injury to the left eye, which appeared as corneoscleral tear along with the limbal area with full chamber hyphema, and we categorized it as zone 1 injury. Patient was PL negative. There was low IOP digitally, and NCCT orbit also showed abnormal globe contour. And when we started with globe exploration, we found out that there was a scleral tear with posterior extension beyond 5 mm, so it was a zone 3 injury, along with uveal prolapse. So management included left eye corneoscleral tear repair with AC wash with intravitreal antibiotics along with B-cell implantation. And so we started the patient on topical and systemic antibiotics and steroids and cycloplegic. We did a post-op B scan at 6, which showed retinal detachment. So it is a hidden casket because these non-penetrating trauma to the eye can cause significant hidden posterior segment pathologies, which are usually missed by a lot of residents because they are in the peripheries, and not a lot of residents are trained to examine their peripheries. It can include vitreous hemorrhage, traumatic retinal detachment, dialysis, macular hole, traumatic optic nerve avulsion, choroidal rupture, or shaken baby syndrome or commotio retinae. So take-home message is we need to aware and educate the general public so that we can have prevention, because prevention is better than cure. As we saw in the first slide, that the most common cause of ocular trauma is RSA, which can be avoided if we wear helmets and protective eye gear. The golden hour of trauma should be followed, and we should go ahead with timely intervention, and we need trained vitreoretinal professionals for timely diagnosis and intervention of the same. Thank you.
So you had 4 cases that
Yes,
you
sir. Yes,
presented. In the third case, you said you felt that it was endophthalmitis,
Yes, sir.
and in the secondary intervention, you even put the IOL. Somehow, I feel that if there is infection, we can avoid IOL for a next stage,
Yes, sir.
rather than first let the infection subside, the inflammation goes down, and then put any other intraocular thing.
Yes, sir.
The third case, I slightly do not agree with the approach that you've done.
And the macular hole was there in the second case?
Yes,
right?
ma'am, yes, ma'am.
How early you planned for the surgical intervention?
Ma'am, actually the patient was from a village, so she did not know that she was having this injury and she was having this problem since a very long time. So when she came to us, we planned after like 4 weeks, within a month we planned her for the surgery.
Just to pass on the message, like there is 40% chances of spontaneous closure as well.
Yes, ma'am.
So if the vision is relatively good, we can observe up to 3 months.
Yes, ma'am.
And like this case, I think definitely required surgical intervention. It looks little large
Yes,
macular
ma'am.
hole. Fine.
Thank you. Thank you.
Right, we'll have the next speaker, Dr. Himani Prajapati. She'll be speaking on referral patients and initial management of pediatric ocular trauma, a cross-sectional study.
So, good afternoon, everyone. So, pediatric ocular trauma accounts for 30% of eye injuries and 8 to 14% of childhood blindness globally. Despite the advances in the ophthalmic care, delayed or inappropriate referrals and inconsistent initial management can lead to poor outcomes. So, this study analyzes the pattern of referrals, initial management and prognosis of the trauma, identifying gaps in the treatment protocols and accessibility to the specialized eye care. This will help us to improve the early intervention strategies and optimize outcomes. So this study was conducted at MNG Institute of Ophthalmology, Ahmedabad for 1 year. 0 to 15 years of the cases were included, referred from different facilities like primary healthcare centers or general practitioners or other ophthalmic facilities. Cases with congenital ocular anomalies, pre-existing conditions or incomplete records were excluded. Demographic, clinical and referral details were collected. Clinical assessment was done and assessment of the initial management provided at the referring facility was studied. Informed consent was taken from parents or legal guardians. So my results shows that 100 out of 100 referred cases, 59% were male and 41 were female. 62% were referred from the rural areas and 38% from urban areas. 88% belong to lower socioeconomic class and 12% belong to middle socioeconomic class. As you can see in the graph, most of the injuries occurred at the playground and followed by home, workplace of parents or guardians and then school. Penetrating injuries comprise of a 68% of the injuries, followed by adnexal and blunt injuries. Different agents were seen in this as a causative agent. So corneal tear was the most common diagnosis, with corneal tear combined with limbal or scleral tear had a higher number in presentation, followed by lid tear and traumatic panophthalmitis. Maximum patients were referred from the ophthalmologist, that is 42%, due to the severity and complications, followed by general practitioners due to inadequate setup like pediatric facilities and general anesthesia facilities, followed by severity in the cases and patients' refusal for the treatment. So 81% of the cases were presented within 3 days, where the majority were due to severity of the cases, followed by inadequate setup. Other reasons were complications and patient refusal for treatment. So main reason for the delay of the presentation was due to multiple consultations, that is 43.24%, and other were inaccessibility to the higher centers and lack of awareness. Out of 100 cases, only 4 cases were given the general urgent surgical management required and was referred due to complications. So my discussion is male predominance was seen consistent with the previous studies, showing boys engaging more frequently in outdoor and high risk activities. Limited access to specialized eye care and lower health awareness in these populations likely contribute to delayed presentation and increased complications. So all the findings underscores the need of urgent awareness programs about safe play environments and household safety measures. So school-related injuries were least common, indicating the relatively safer environment, and the peripheral health centers accounted for 26% of the referral, emphasizing the need of better equipped primary care centers. And lack of parental awareness and financial constraints and inaccessibility to higher medical facilities further contributed to delays. So highlighting the urgent need of for better primary care management, referral systems and accessibility to the specialist care is needed. So my conclusion is pediatric ocular trauma remains a critical yet neglected issue, especially in the rural and lower income communities. Most of the patients were referred only with the basic treatment without the proper counseling and of the urgency. In reality, many of these patients required specialist care from very beginning, highlighting the significant gap in initial management. Delays in the treatment combined with the inadequate early intervention led to the complications, which could have been avoided with the timely and specialized care. Strengthening the primary health care infrastructure, improving the referral systems, and raising the awareness of among the caregivers can help reduce the burden of preventable blindness. So these are my references. Thank you.
Thank you. You mentioned the age group as 0 to 15 or so.
Yes.
So do you have any idea what kind of injury was the infant getting?
Most of them had wooden particle injuries because...
Sorry, what particle?
Wooden material, any sort of wooden material.
Infant?
Chip, yes.
Okay.
And 1 or 2 cases had also like hook, while feeding mothers, blouse hook was caused the corneal tear also. So.
Right. Ashish,
You presented the referral patterns, and I would say that any patient who has injury should be dealt urgently unless the injury has been for last few days, you know. If the patient has an injury on the same day, it is better to operate and even give infections, because your patients had a lot of them had panophthalmitis.
Yes.
So that is a very right thing that you said, that we need to aware our general public and general practitioners, and we need to have certain tertiary care centers who are ready to operate on the same day,
Yes.
thus preventing the infections. So overall, as a cross-sectional study, the referral patterns are nicely said. Then thank you, sir.
Thank you, sir.
Thank you.
Thank you.
We'll have the next speaker, Dr. Pradhan. I'm sorry I can't pronounce your first name, it's a little tongue twister. You'll be speaking a punch, a leak, a hospital trip, endophthalmitis following blunt injury.
Yeah, good afternoon, judges. Thank you, scientific committee, for allowing me to present here. So, I will present one case of endophthalmitis that's following blunt injury. So, it was a 44-year-old male who had presented to us with sudden diminution of vision in the right eye for 3 days following blunt trauma with fist with from his friend's hand actually. So diagnosed also as endogenous endophthalmitis, and AC anterior chamber was given, and intravitreal vancomycin and ceftazidime was given already 1 dose. But there was no history of any other systemic problem and no history of fever. So when the patient came to us, he told he had a history of radial keratotomy that was done 27 years before. Patient presented with PL positive vision. There was presence of 1 millimeter of hypopyon, and vitreous exudates was there in ultrasound B scan. So this ultrasound B scan shows this plenty of vitreous exudates, and retina was attached, but there was thickened choroid. So the choroid was 2.08 millimeter. So, is it endogenous endophthalmitis? So, before coming to the conclusion, so there are two things to be pointed out. This one is spontaneous corneal perforation, that is rare, but can be a long-term complications after radial keratotomy. And as the patient had a history of trauma, and the keratotomy area can open up momentarily and can be the source of infection. So, so there is the history of trauma, this is one point. Another one is history of radial keratotomy. So these 2 points was against the endogenous endophthalmitis, and there was no other systemic problem or any fever we could find. So vitrectomy was done, and the lensectomy was done as the exudates was present at the anterior capsule and the posterior capsules. And anterior capsular rim was kept intact during surgery, keeping in mind that we can put secondary IOL later. So this was subsequent visit fundus photo of the right eye, the view become clear. So after post-operative period, we have given intravitreal antibiotic injections also. So the gram-positive cocci was cultured, Streptococcus viridans was grown in culture, and multiple intravitreal antibiotic like vancomycin and ceftazidime was given after that. So he was also started on topical antibiotic and oral ciprofloxacin and IV antibiotic also. So this is 8 months after the primary surgery. The vision was improved with +10. The vision was 6/9. So we planned for the secondary IOL implantation. So base corrected visual acuity was improved to 6/9, and we put the secondary IOL at the sulcus 3-piece IOL after 8 months after the primary surgery. So coming to the discussion, in case of radial keratotomy, the depth of the corneal incision can be like 80 to 90% of the corneal thickness. And for endophthalmitis to occur, the organism must traverse the descending membrane to enter the anterior chamber. So for the trivial trauma, sometime can, as because this already the depth of incision 80 to 90%. So sometimes the trivial trauma can cause the breach of the descending membrane and can cause endophthalmitis. So it may occur without the history of recognized perforation. So the patient may have an unrecognized perforation after blunt trauma, or could have been subsequently developed a microperforation from the necrosis at the base of the wound. The microperforation might not have clinically evident, especially if stromal edema later sealed the site. So for my take-home messages are from this case is with incisional refractive surgery, it is important to be aware that an occult perforation may occur at any time with trivial injury. Though blunt trauma rarely causes endophthalmitis, it can happen in post-radial keratotomy cases. And when vitrectomy is planned in post-radial keratotomy eyes, we should be very cautious and to keep infusion pressure low to prevent the opening of the corneal incision areas. Thank you. Thank you.
So when you did the vitrectomy, there that time also you could not find any break in the radial keratotomy incision.
No, there was no leakage from that side. We kept
No,
the.
did you
Yeah.
press the cornea or try to see that is there any leak somewhere? Because
Yeah, we tried and
you could not find.
but we couldn't find any tear there.
Yeah, because
So-
one of the case, I think we did the suturing as well. Like when
Okay.
the vitrectomy, we do know if there
Yeah.
is a leak, sometimes it may give way, like the sir was telling, no?
Yeah.
So better to recognize and suture until it heals,
Okay.
I feel.
I think they have said it very rightly, especially in RK cases.
Yeah.
And you should not worry in case even if the RK is opening up, all you need to do is suturing.
Yeah.
As madam said, that suturing is very important.
Yeah.
And of course, that's a very valid point what Dr. Ashish has mentioned about the break.
Otherwise, it's a good, you've managed it very well, and especially you've preserved the capsule so that you can put the IOL later
Yeah.
on.
But it's a good case you have presented, a good case.
And
Yeah, I
it's something
searched
to
a
ponder.
few literature, so they were showing sometime the stromal edema can close the
Yes.
momentarily it can open and this infection can go inside, but after that it was closed, maybe self-sealing
Right.
it was.
I hope all of you are aware what is RK, the radial keratotomy,
Yeah.
which was being done with the diamond knife to flatten the curvature of the cornea to reduce the myopia. Right, so do we have any more speakers who have not spoken over here? I'll go back again, who have not, Parul
Yes.
Mittal, Dr.
There's
Raj.
one. What's your name?
What's your good name?
Top.
Topic?
Third last.
Please come over.
Come. Rajni Yadav, Parvez Ahmed, and
What is the topic?
Ketaki Shah, Siddharth Madan. Okay. So probably we'll have her as the last speaker then.
Okay. So you are Dr. Preeti Singh? So Dr. Nikita Ahuja will be presenting. She's a co-author. The chief author is Dr. Parul Mittal. Okay,
Should I start? Good morning, everyone. I am Dr. Nikita Ahuja from AIOS Bhopal, and today I would be presenting a unique case of intraorbital wooden foreign body reaching the orbital apex and its successful management. So, ocular trauma is the leading cause of uniocular visual disability. Among trauma, intraorbital foreign bodies are common, with wooden foreign bodies being rare. Wooden foreign bodies present higher infection risk due to their organic nature. Pediatric ocular trauma poses a risk of amblyopia and long-term psychological damage. Effective management of complex pediatric cases requires prompt evaluation through imaging and multidisciplinary collaboration. I would be presenting to you a 5-year-old boy who, after 15 years post-injury from a fall, sustained right eye injury and from a wooden stick after an 8-foot tree fall. Presented with acute distress, proptosis, periorbital edema, patient was uncooperative for vision and ocular movements. As we can see, there is impingement with tissue desiccation. Examination revealed right lateral infraorbital laceration, visible wooden foreign body on the right infralateral side impinged at 7 o'clock, resembling devitalized tissue. Conjunctival ecchymosis and mid-dilated pupil. Posterior segment showed scleral indentation mimicking infratemporal RD. This is the picture showing intraorbital wood impingement at 7 o'clock position. With investigation, we first ordered for X-ray orbit, PA and lateral view for structural information. After that, on CT findings, we could see a foreign body from external orbital surface up to orbital apex, abutting the posterolateral surface of the globe, abutting right lacrimal gland and lateral rectus muscle. Optic nerve was appearing to be stretched. So for management, we proceeded with initial treatment with broad-spectrum antibiotics, topical moxifloxacin 0.5% and eye drop natamycin 5% with prophylactic tetanus toxoid. And surgically, we took the patient under general anesthesia and infraorbital laceration was widened and 4.7 centimeter wooden foreign body was successfully extracted. The primary repair was performed, and as you could see, there is a approximately 5 centimeter long wooden stick which was successfully removed. So on post-operative course, there was favorable recovery of vision and consistent retinoscopy reflex was observed in all the meridians. There was marked improvement in proptosis, resolution of retinal indentation with normal retina, with normal retinal appearance was found. So CT is commonly used but has limitation in detecting wooden foreign bodies. Prompt surgical intervention is critical for preventing severe outcomes like orbital cellulitis or abscess formation or brain abscess. Pediatric cases are extremely rare, with injuries extending to the orbital apex even less common. Previous studies like in Shelsta et al. And Tas and Top et al. Reported no significant pediatric cases. In these studies, there were sample size of 23 to 32 cases with none of being in the pediatric age group, with most injuries occurring in the young adult male from 21 to 22. In this case of a 5-year-old child presents diagnostic and therapeutic challenges not widely documented. Scleral indentation from intraocular foreign body impingement can mimic infratemporal RD, highlighting the need for careful differentiation. So to conclude, early diagnosis and multidisciplinary approach are essential. For managing such cases, high risk of infection due to porous nature of wooden foreign bodies necessitates early intervention, and favorable outcomes can be achieved with vigilance and thorough management. Thank you.
Thank you. A very good presentation. What was the B scan picture? Did you try an orbital mode of B scan?
Ma'am, actually, at our center before, if the patient was very uncooperative, and before operating such cases, we usually avoid B scan, or we, in some cases where it is important, we do gentle B scan.
No, this is a closed globe injury, right?
Yes, ma'am.
It's not an open globe injury.
And because the child was highly uncooperative, we did not go for a B scan. And on post-op POD day 3 to 4, we did a B scan and it did not show any, retina was on and vitreous was echoic, showing some PVD changes, and there was no CD or RD.
Yeah, orbital mode of B scan also helps, like in these cases, you know. Was there a choroidal abscess or any indentation? Like it helps us to know the diagnosis. Yeah. Anyway, well managed. Another point I would like to tell, like wooden foreign bodies retained. There is a high risk of degradation and retaining foreign body chances also will be there. So thorough removal and measuring the size in imaging is very important. So any points you would like to add?
I think you have said it rightly. Only thing I'd like to add is that when you're removing these foreign bodies, especially the wooden part, you need to remove it very slowly. Don't be in a hurry to remove it, because otherwise you're likely to damage the surrounding tissue. So it's a take-home message that when you remove the foreign bodies, especially the wooden, of say about 5 centimeters, you said?
5 centimeters, yes.
So that's a big foreign body. So in order to avoid the damage to the surrounding tissues, do it with the forceps or with the help of, of course, always better to use forceps because you're likely to injure your fingers as well. Do it very, very subtle, very slowly in order to avoid the damage. And of course, I think yes, you rightly said the CT scan sometimes is a little difficult to go ahead with the wooden foreign body. I don't know if MRI can help.
So because it was an emergency
the only
condition,
thing about MRI is that we have to be very careful that it is a wooden only, it is not a metallic thing.
Yes.
So you, for a trauma, I would still feel that it is, because it's very difficult to ascertain from their history what has gone wrong at times,
So
especially
CT
the
with
children.
contrast will help. What I have
So
seen in
CT
my-
is
yeah.
always better. That
And 3D imaging and all now with advanced imaging, I think we can diagnose better. And if MRI again under sedation, for pediatric cases doing MRI is a challenge.
Definitely under sedation, but yes, contrast, and he rightly said that we are not sure what type of foreign body. If it is metallic, then you can't go ahead with the MR, right? That's another drawback for that.
You know, I had a patient recently who had proptosis, and before we could think about anything, we were like, one of our doctors had written an MRI because we thought that there is something going wrong behind the eye. So the patient, the parent said that the child will not go into the MRI machine. CT scan took just 2 minutes. So CT scan is a very fast modality, especially in trauma cases. So that is very
true.
positive.
Right.
Sure.
Thank you.
Thank you.
Yeah.
Thank you.
That brings us to the end of this session. Everybody presented very well and very nice documentation. And it's very difficult for us to pinpoint that who is first and who is second. So let's hope that we all three have given marks separately, and the best person is just maybe a score higher or less.
We won't
Best
tell you
wishes
the
to all
marks
of you.
right now. You'll get it through the committee also.
Thank you all. Yeah.
But thank you very much. We conclude this session, and we'll just collectively make the list of the marks also.
I think we'll give it to them.
Yeah. Can we have all the presenters over here, whoever is present?
Nice presentation. आप सब लोग post graduates हैं?
DNB, MS or whatever.